Laura, I will kind of give it up to you right now, and you can kind of give a little bit about your background and why this was a good fit.
Definitely. So, hi, everyone. Nice to meet you. I'm excited for you all next year. So my name is Laura. I am the current Seymour doula. I'm currently the only one and the second one that has been through the AmeriCorps program since it was rebooted at Seymour. Um, and prior to joining AmeriCorps in this position, I had been serving as a medical interpreter. I speak Spanish fluently, and like a lot of the patients who I would work with would either be pregnant or trying to become pregnant, and just navigating the health world as an immigrant or non-English speaker, there's just a lot of barriers to overcome. And I really wanted to take a bigger role learning about the healthcare system, learning about interacting with patients, learning about maternity support services. And I was very familiar with CMAR and its mission, and it just seemed like such a wonderful opportunity to serve for a year, to grow as a person, to learn, and to learn how to be a better patient advocate and partner. So this year has been truly moving and meaningful for me. I've experienced tremendous personal growth, which uh, I could not have even fathomed, everything I would have learned this past year. So I'm really excited for all of you embarking on this journey.
Thank you, Laura. Um, Even though we only have four people here, the elementary school teacher in my past life is still in me, so I would ask you to just raise your hands on a little thing there, so we can have some kind of order. So if anybody's got a question, please raise your hand and give me a call. No questions? Everybody came hoping somebody else would ask a question. There we go. Emma.
I got a whole list of questions. No worries. Hi again, Laura. It's good to see you. I'm wondering, can you talk about what the type of support you provide looks like for folks during their pregnancy and then in the postpartum period, and then also specifically with postpartum, how long, if at all, do you support folks? And is that something that is influenced just by the patient that you have, or is it standardized?
Yeah, so I am the MSS, the Maternity Support Services doula, and CMAR has an MSS department. So the way that generally works is like if a patient is pregnant, knows they're pregnant, thinks they might be pregnant, they go first to one of our CMAR OBs, and OB does pregnancy test, confirms, yes, you're pregnant. And then if they're eligible for MSS services, they get sent to my team. So then someone on my team will do a intake, which is just like, who are you? Where are you from? How long have you been here? What insecurities are you facing? How can we support you? And I would say I get patients sent to me. And so then you receive MSS services throughout your pregnancy, and that includes nursing support, social work, and a community health worker. And sometimes we get patients who are 5 days pregnant and they enroll in MSS services at the beginning of their pregnancy. I recently had someone who was 36 weeks pregnant, and that was the first time they were seen by a doctor. So you really see, sometimes you're working with patients the day, from the very onset of the pregnancy, and sometimes it's very little time before they actually give birth. Um, and I would say each patient is different in what they're looking for. Sometimes if it's a first time mom and they're younger, you'll be doing a lot of like birthing education. So you'll be talking about, what are your options? What do you want delivery to look like? What can you expect during each trimester? What can you expect when you actually go into labor? I had one patient ask me, can we go over nutrition and just general foods that are good to eat during pregnancy? So there's a whole span of topics that you can work with the patients prior to delivery, and some of them like to have constant communication. So especially in the third trimester, I have patients who have called at least weekly to check in on and have conversations. Some prefer maybe once a trimester, which is generally the MSS timeline. But I would say on average, you will have at least 5 touch points before birth with the patients. And then during birth, I mean, each patient is different. So again, you tell them, when you want support, tell me. Since I spoke Spanish, a lot of the patients would say, I want you to meet me at the hospital. I don't speak any English. I don't know where to go. Like I want another person with you. But I have had patients who have said, I want to wait until I'm, in a lot of pain and will need your help. So everyone's different. But then during labor, like you are labor support. So making sure that the mom feels comfortable, supported. Sometimes she might have her partner there or her mom there, or I've had people even have like their children with them. And so, you might want to take a back seat because you're like, oh, they have their loved ones, but it's really your role as the doula to make sure that the mom feels supported. And what that looks like is even working with family members to say like, hey, like, I think mom needs this. Like, why don't we, try helping her? So you're facilitating that environment. Um, uh, and then postpartum, I would usually go, like, I usually stay 2 to 3 hours after birth. Every birth I've had, there has been an interpreter, and the interpreter usually stays 2 to 3 hours after birth. So we're usually all there. We do like the orientation to postpartum, make sure mom and baby feel supported, everything's good, and then I head out. And then I usually go the next day and make sure like all hospital forms are filled out. If mom's had breastfeeding, like in the first 24 hours can be really hard. So I do a lot of breastfeeding consultations or um, working through those worries with mom. Because a lot of times, they'll say, I'm not producing enough milk. Should I start bottle feeding? And, providing comfort because that's just completely natural. So making sure that they feel good about what their bodies are doing. And then the way the program works is they are with MSS for 3 months postpartum, and then they get transitioned to infant case managing, which their child will then be with until the age of 5, I believe. So, or maybe it's 1. But anyways, um, I'm usually with them 3 months postpartum, still answering questions like, oh, my birth certificate hasn't come in, or my social security card hasn't come in, or I'm having a really hard time getting food for me and my baby, or I need a stroller, or I'm going through diapers too quickly, stuff like that. Like so many things can pop up, in addition to like my body is still changing. It doesn't feel like it's back to normal. So you're doing doula support, but you're also doing a lot of other support and advocacy as well.
Wow.
Thank you so much.
I got a couple follow-up questions to that. When you said at 5 months or after 3 months, you said they are transitioned to infant case manager. Is that through WIC?
It's still through CMAR.
Okay.
But like MSS, it's all like coded differently through Medicaid. So like MSS is one program, ICM is another program, and then WIC is an addition to both of those. So you can do MSS and WIC and ICM and WIC, but you cannot be both MSS and ICM. And that's
Gotcha.
partially because after 3 months, Medicaid won't reimburse MSS services anymore. So there's been times where like a patient has called me 6 months, and they're like, I'm not in MSS anymore, but I have this question. I don't know who else to ask. Like I, of course, will answer the question and then try to get, coordinate their care. But just as a general rule, that's usually how it goes.
Gotcha. When you were describing the services you provide, it just really struck me that they're expansive. There's a lot of them.
Mm-hmm.
And you went through the training at Bastille, correct?
Mm-hmm. Yeah.
So, can you talk about how well did that training prepare you
Mm-hmm.
for what you had, and then for the things, of course, that pop up that it really can't prepare you for?
Mm-hmm.
How well did CMAR staff, or did they, help support you in areas that, okay, I need help and I'm a little over my skis here? So.
Mm-hmm. Yeah. So within my first week of starting the position, I did a 4-day intensive doula training at Bastille. And that doula training is really good for like learning actual doula skills. But I would say it's nowhere near like, it does not even cover the surface of what is done at CMAR. And I will say the best steer training is definitely aimed towards people who are citizens of this country, have a lot of education about like what their birth is supposed to look like, and comes with a level of privilege that a lot of our patients don't have. So I think like the pain management techniques and learning about different options during birth, or breastfeeding, or the stages of birth, like you learn a lot in that training. But I will I will say it's not super expansive. And um, when within my first month of CMAR, I like shadowed everyone in the MSS department twice. So we currently have 4 community health workers. So I shadowed each of them twice. I shadowed the social worker, and then I shadowed the nurses. And so that really helped me learn more about what our patients are facing and some of their day to day, which is great because then when I started having my own patients, I'd be like, okay, this patient is 20 weeks pregnant, and they had meeting 1 and 2 with the community health worker and 1 meeting with the nurse. I know, and you have access to Epic, so you can read all of those chart notes. And I'm just like, okay, I know what they're facing. I know what was discussed. Like, let me build on that information to just like help reinforce it and make the patient feel more supported. And then my office is right next to the MSS supervisor's office, as well as a community health worker and a nurse. And so, like, if a patient would mention, like, hey, this happened to my body, I don't know if that's normal, I could go next door to the nurse and say, hey, like, patient Z said this to me, like, what do you think? And then she can either say, oh, call her back and just provide some reassurance, or let me put her on my calendar and we can delve into this deeper. And same with like a social worker. I'd be like, hey, patient X mentioned that her partner did this to her. I'm not sure if things are okay at home. Then the community health worker would be like, okay, that's great. Like, I'll check in with the social worker and escalate to our supervisor as needed. So, um, like you're solitary in your own office, in your own space, but the team is so accessible, especially in the beginning. Like you're just going to have so many questions, like so much is going to be thrown at you that you've never even thought you were going to see or deal with. Um, and absolutely, you should never be dealing with this alone. Because these people have very, very complex health and social needs, and you want to make sure everyone is looped in and knows what's going on. Because things will come up and they will need all the support that they can get.
Thank you.
Can I
Let's
ask
see
a
here.
follow-up on that question?
Oh, sure.
I'm
Absolutely.
sorry. My internet is a little bit fuzzy, so I don't know if I'm cutting somebody off. With an accessible team during like the pregnancy and postpartum visit sounds great. What do you do in the scenario that you come across something like in your first delivery or whatever, where like your team really isn't accessible immediately? What's your toolkit for dealing with that?
Yeah, I would say the team is always accessible. Honestly, your supervisor will give you their cell phone number. And like my very first delivery was a patient who was houseless. And she thought she was in labor, but she wasn't, and she needed to go back to the shelter, but buses weren't running, and the shelter had a curfew, which we had missed because we were at the hospital. Um, and like patient was freaking out because she's like, I don't know where to go. And we had like requested a social work consultation at the hospital that was denied for whatever reason. And I didn't know what to do, so um I called my it wasn't Richard. I called my AmeriCorps supervisor at the time, and I texted my MSS supervisor, and I was like, hey, like, we're stuck at the hospital, no transportation, because you can't drive the patients, like, no transportation. I really don't know what to do. And, he was able to escalate it to the medical department at CMAR, and then a CMAR doc was able to come um, to our hospital room and like personally called the shelter himself and like all of this stuff. So like things will happen, especially in the beginning where you're like, I have no idea how to deal with this. Um, but there has like never been a scenario where something like, especially, like someone homeless getting like thrown back into the street at the hospital. Like there's never been a moment where I have not been able to call either Richard or Paula and be like, this is, what's going on. Um, and then as you go to the hospitals more and more, you will start to recognize who the CMAR docs are. And they're always really good advocates advocates for the patients too. So like if you feel like something isn't right, I would definitely say don't guess, because you are dealing with people's lives and you should never try to do something if you don't know what is right, especially in a medical capacity, but always escalate. And sometimes you'll be in an uncomfortable position where like people will push you, like the social work consult was denied. And that's a little uncomfortable, especially as a doula. But like you have to be that person to push back for the patients, especially if they are like non-English speaking. I mean, then just also being pregnant is a vulnerable position in the first place, but you have to be the one to like really push back because no one else will. And it's your job to make sure that all of their needs are met.
Thank you, Laura. Do any of our other guests have questions? Holly, Morgan, Mosday?
Not yet.
Uh,
Thank you.
Oh, sorry, go ahead.
Go ahead, Holly.
Okay, so I was just wondering, for myself, I've been to multiple births that were unmedicated and had my own, so I have a lot of information about that. But the only times that I've been in the setting where there's been medication used during pain medication, it's been with my sister. So I was more focused on my sister than paying attention to that. But I'm assuming you said at Bastyr they provide all of that information. So if your client is wondering about that and how it's going to go, you'll have that knowledge, I'm assuming. Is that true?
Yeah. Yeah, Bastyr will tell, and it's different from each hospital too. So like Bastyr will give you all possible like medication options for a birth, but like for example, nitrous oxide is one of them, but Swedish hospital doesn't carry that. So like something else that I did within my first month of joining CMAR was just calling each hospital and being like, hey, like what are your procedures? Because some people allow 2 support people and a doula. Some people only let 1 support person and a doula. Some people only allow 1 support person, not a doula, in an OR. So each hospital has different rules. So I would just call like, what are your pain management options? Like, what is your support person visitation? Like, what are your visitor policies? Like, what amenities do you offer to the patients? So that you have all of that information. And then in terms of like medicated births, I'd say a lot of my patients, half of them want a medicated birth and the other half don't. And some just aren't sure. So I would usually start the conversation and I would say, as a general rule, these are your options. And then I would always encourage them to talk about it with their provider because, the provider has the deeper understanding of their medical history and what is and isn't a good option. Because sometimes, depending on the medical needs, sometimes it is like 90% recommended that they use pain medication because of like a condition, or sometimes it could be unsafe. So I always tell them to have the conversation with their provider and we can discuss further. And then
Okay.
usually during like the process of receiving an epidural, some hospitals actually don't allow the doulas in the room. But if they do, usually I'm not involved with that procedure. Usually if the support person, if they're like partners there, I'm there with their partner being like, okay, this is, really scary. Some people are really scared for an epidural, which is understandable. And so like, she's really scared right now. Like, let's help her count to 3 and get through her contractions and feel supported and calm so this can go quickly kind of thing.
Okay.
But yeah,
All right.
Bastyr will
Thank you.
definitely provide a lot of training for that.
Perfect.
I have a quick follow-up on that. You mentioned the different hospitals and the policies they have. What dictates which hospital a patient is going to? Is that dictated by insurance, location, or a combination of both?
It's all dictated through where they receive their OB care. So if they're getting their, like each CMAR clinic delivers at a different hospital. So like if you're going to CMAR White Center, you have to deliver at Swedish. If you go to CMAR Des Moines, you have to deliver at St. Anne and Burien. However, some patients receive CMAR MSS services, but get their OB care elsewhere. So I've delivered at hospitals outside of like where CMAR doctors have practicing power. So that's like a good thing to know, is that if a patient is receiving their OB, wherever their patient is receiving their OB care, for example, if they're getting their OB care at Auburn Multicare, they should know, but just also reinforcing like, hey, like, just so you know, you're going to be delivering at Auburn Multicare. Or I had a patient that lived in Bellevue and wanted to deliver at Overlake. And so, but she's getting OB care at CMAR Seattle. And we're like, you're going to deliver at Swedish. If that's not something you want, like, let's get you set up with another provider quickly, so that you can deliver at the hospital you want. So yeah, I think that's all insurance though, which is important to know, because you don't want them to get hit with like, I mean, birth is like $30K, so you don't want them to get hit with that bill.
Okay, does someone else have a question? Oh, Holly, you have another question.
I just had a follow-up to that, what you just said, and now I've forgotten what it was, unfortunately, as soon as you called on me. So I guess if I think of it again, I'll raise my hand again. Sorry
Sure.
about that.
No problem. And if you want to type it in the chat, so you don't forget it, I'll make sure it gets said or asked, or that's a way to remind yourself. Okay, Emma.
In the scenario that you do have a patient that gets a C-section, and you are or aren't allowed in the room, what does your support from that point on look like?
Yeah, so some hospitals for whatever reason don't even allow doulas in the OR. So it all and also sometimes numbers are constrained with an interpreter. So like if they have an interpreter and a partner and a doula, like generally 3 people is too much. So I would say if someone has partner support and an interpreter, also checking with it's hard because it's the anesthesiologist's call of how many people are allowed in the OR. And so obviously each person's different. And sometimes in emergency situations, you don't know who your anesthesiologist is going to be, so you can't plan ahead. So that's definitely a conversation you have with your patients up front if they are going to have an elective C-section and know in advance. But you absolutely still can have doula support. Because sometimes like their partner will be like, I'll go to the hospital with them, I'll be in the room, but the OR terrifies me. And so, like you're usually sitting at their head, kind of like talking to them in a quiet whisper, because they like the ORs to be quiet, and just like letting the patient know they're okay, checking in that there's, nothing wrong. And then, helping them get that like skin to skin and first touch after birth. And then, if I'm not going to be in the OR during a C-section, sometimes the patients will be like, I still want you to go to the hospital with me, help me get checked in. And you like sit in their room while they're in the procedure. Other times they'll be like, I have my partner and my sister. So I'll be okay going to the hospital and during the C-section, but you stayed 2 days postpartum after a C-section, and they'll be like, my family has to go back to work, so will you come and give me some support at the hospital? So, and then also like you'll learn in your best year training, like there's tons of support that a doula can offer during a C-section. So just because a patient is going to have a C-section doesn't mean they can't have a doula. Then also just like preparing for, yeah, a lot of times, someone will be laboring and trying to have a vaginal delivery, and then something goes wrong and it has to be a C-section. So paying attention to that part of the training, and then also having those conversations with your patients, because it can be very hard emotionally to not have your birth go the way that you want. And so that's when a doula becomes vital, to really coach them through that, and, say like, it's okay to be upset. I know your birth isn't going the way you planned, but like we got to think about baby right now, and we need you and baby to be safe. So like, let's talk through these options.
I had a question.
Mhm.
Because you've talked many times about how personal giving birth is, and
Mhm.
I was fortunate to witness twice, and it very much so is. But as a volunteer, as a doula, everybody has to set their own boundaries for their
Mhm.
position, right?
Mhm.
When I worked with at-risk youth, I would tell them, always call or text, leave a message. I may, on a weekend or evenings, I may not be able to answer it at that time, but I will definitely be able to hit the ground running on the next work day. I'll know what's going on and be on top of it. So not necessarily what boundaries did you set, because everyone has their own, but can you talk about a time when maybe your boundaries were tested?
Mhm.
And then how did you handle that?
Yeah. Um, so that's a great question, and I'll say it's twofold. One, you will like have a doula phone where patients can call and contact you. And I had a special ringtone and text notification for that phone that like if I was sleeping and at 3 a.m. I heard, this noise, I knew that it was my doula phone. And so I would always answer it because you never just because patients know that that's a cell phone number and they generally will know that it's accessible. Um, and clinic close CMARC's clinics close at 5 p.m. and there is an on-call doc, but it's very hard to reach that person. So generally you are like a point of contact for patients because they know it's someone that who's reliable and they can call. Um, and so when I hear that phone, I'm always worried because and I always answer because it's like you never know what's going on and you don't want there to be an emergency. Um, and so if I answer the phone and it is a true emergency, then like I help either get them in contact with the on-call CMAR doc or advise them like, hey, let's go meet each other at the hospital or something like that. If it's not an emergency, and there have been times where someone's called me at like 9 p.m. and they're like, hey, I'm trying to talk to this person in the checkout line, but they don't speak Spanish. Like, can you interpret for me? And I'd be like, hi, like, I'm so sorry. That sounds really stressful, but I can't stay on the line because I need to make sure if another patient's calling me, like they need to be able to reach me. Um, but like, thank you for calling me. Try to use Google Translate or something like that. Like one time I had a patient's husband call me because he left the hospital to go get food and then he was lost and he couldn't find his way back to the hospital. And he kept on calling me like every 10 minutes for 2 hours and I was very patient and I was giving him directions and then afterwards I, I was just like, okay, look, like you're in the hospital now. There's the front desk. They have an interpreter screen right there. I need you to go up and talk to them and say you're lost. Like I cannot keep doing this for you. So it's definitely a balance of wanting to be there for your patients and wanting to support them, but also standing up for yourself and your needs because they will quickly learn you're a very accessible and dependable person. Um, just keep that in mind that when they're asking you things like they're in a vulnerable position, but there is a time and place for everything, and you should not drop what you're doing, to help with every obstacle that comes along the way. Be like, "Hey, can we table this discussion for Monday when I'm back in the office?" Or maybe you should try reaching out to this resource or doing this. Like that's not what I'm doing right now.
Awesome, thank you. Holly, you have
Mhm.
a question?
Yeah. So as you're talking, I'm noticing that there is a lot of extra information that just has to do with the general experience of the client.
Mhm.
And it sounds like there's so much involved that you need to know. Is all of this, did you pick it up along the way, or was it through the shadowing that you noticed all of these things? I mean, was it part of the training, or did you just have to kind of pick it up on your own?
Yeah. Um, I will say that you learn like a lot, and I think it all depends on how quickly you get your first patient. Um, because my first month was very much just working very closely with my MSS team, and like you sit in on their patient calls, and so you get a general idea of like I mean, each patient is different, but there are general needs that each patient has. Usually people need to be connected with food banks. Usually they need help getting transportation to and from their appointments. Um, and there's just like general support that they need during birth. So you get a good idea of like what's gonna come up in these situations just from your shadowing and your best year training, but there will always be things that happen. And I think like the biggest thing is when something comes up that you don't know, one, definitely telling the patient, I don't know how to deal with this, but let me find an answer for you. And then following up. You know, if like something, if a patient asks you something and you don't know the answer, say like, I really don't know, but that's a great question. Let me find out. If it's a non-emergent situation, give them a timeline. Like, I'll call you back in a week, or I'll call you back tomorrow. And then your MSS team is super accessible and you can be like, hey, patient X mentioned this to me. I don't know what to do. And sometimes they'll take over because it'll be a more serious issue than a doula should be dealing with. And other times it'll be like, oh, hey, yeah, like, send them to this resource. And then you can call the patient back and be like, oh, I talked to, you know, the social worker, and this is what we have to do. So like there is stuff that's covered in the training, but then a ton is learning on the job. And just like as a general rule of thumb, you should never go with something or do what you think is right. There's a ton of resources available to you and a ton of support within MSS. And so just making sure that you follow up accordingly with the patient and with your team, document it in Epic, and everything will be fine.
Great.
I'd like
Thank
to
you.
follow up real quick with that too then. Can you speak a little bit more about how you work with the other departments and how they've been helpful? And maybe, I don't know if you have an example of maybe one patient that just worked with several departments and how you all kind of collaborated to provide care.
Yeah. So we had one patient who was a very high risk pregnancy. So she had a lot of complex medical needs. So she was in contact with the RN a lot, our nurse. And so, you know, like pre-labor, I'd be having conversations with, you know, the mom about like, okay, what do you want your birth to look like? What is birth gonna be like? And let's say we were talking about the stages of labor, and I could just tell she was very overwhelmed and scared. You know, I would go over that information with the patient, and then I would send an Epic note to the nurse and be like, we talked about X, Y, and Z. Patient felt very uncomfortable or had a lot of questions about this topic. I know you're meeting with her next week. I think that'd be really great to reinforce and go until deeper. Or sometimes then the nurse would come back and be like, oh, hey, like I just had a meeting with this patient and she had a lot of questions about her options for laboring, like laboring positions. Can you have a conversation with her about that? Or then like when I was at the hospital, there was like one time where a patient didn't have a car seat, and you have to have a car seat in order to leave. They will not let you take your baby home without a car seat. And so like I quickly called um the community health worker and I was like, hey, like, is there a spare car seat in your office? This patient doesn't have one. And so like birth happened, and then I left, went to the CMAR site, got a car seat, and then brought it back to the hospital. And then also just like helping them get their transportation. You know, like that's a really easy consult with a community health worker or food bank or formula. And then with a social worker, that's usually when something like with their social behavioral needs comes up. So like if a patient mentions, you know, they just had their baby, but they're really sad and they don't want to hold their baby, or they're not connecting with their baby, or they don't feel loved, like that's an immediate escalation to the social worker. Or like if something happened at the hospital, you know, like let's say patient was laboring for 48 hours and really wanted that vaginal delivery, and then it ended up being a C-section. Even if the patient feels happy after her birth, that's still a very emotional thing that she went with. And um, you send in a message to the social worker, and she'll usually fit in like a quick call just to make sure, like, you know, patient's good, and then she'll schedule like a larger call. And that's a good rule of thumb, is after every birth, to send like a mass message to social worker, RN, MSS supervisor, and community health worker, just be like, hey, this is the birth, this is what happened, these are the needs, and like they'll each go out and do their own thing. So like you will never be, or and should never be, the only person that the patient's talking to in MSS. Like there is a whole team and everyone has their own role. And while you're shadowing, you'll learn what each person's role is. And it's really critical that you like lean on each other, because patients are going to have so much support needs, and you should never be doing everything yourself.
Thank you. All right, any other questions? Emma, you said you had a whole page full. There we go. All right, come on, Emma.
I sure do. My internet's being slow again, so if I'm choppy, you let me know. I'm hearing, and I think we spoke also, Laura, about doing mostly phone calls with folks. Is that right? And what proportion would you say that you're like seeing folks face to face outside of their deliveries? And then also, do you ever do home visits postpartum or in pregnancy?
So I know the MSS team and WIC used to do home visits, and it was like a CMAR rule because of COVID precautions that home visits didn't happen. It's my understanding they're going to start back up in August. But that's like a conversation for you to have with your MSS supervisor. And it depends on I guess in terms of just like phone visit versus in person, you will have your own office space. And there's some clinics where there isn't office space, but I would always try to have at least one in-person visit before birth, even if it was just like, hey, I'll be in the lobby of White Center at this time after your medical appointment, and I'll give you these like documents really quickly about, you know, your options during labor, or a list of things to pack for the hospital, just to have a really quick touch point, like, hey, this is who I am, this is what I look like, you know, this is the voice on the phone you've been talking to. Just because it can be really, you know, like kind of what Richard said, like it's a very sacred moment to be. It's a privilege to be allowed to be in the delivery room. Just because you are their doula does not mean you deserve to be there, and you definitely have to treat it with the respect that it deserves. And so, you know, it's scary to allow a complete stranger in your delivery in this very intimate moment. So I would always try to have at least one in-person visit with the patients to connect one-on-one, to be like, hey, this is who I am, this is what I'm going to be doing for you. But phone visits are a lot more accessible for people, so I generally have more phone visits than I do in-person visits. But if a patient likes in person, then I will do everything in my power to find, if they can't, like, you can schedule HopeLink for yourself, so I would do everything in my power to make sure they could get those in-person visits. But it's however, you know, it's whatever they can do.
Gotcha.
And just to follow up on that, just a little bit, when Laura does go out into the field, she is compensated for mileage. Right now it's 60 cents an hour. So, but you're
60 cents a mile.
60 cents a mile. I'm sorry, 60 cents. 60 cents an hour is your compensation as the two. Oh, what was my other part now? In regards to home visits. So if/when those continue, I will work with the site supervisor to make sure safety is addressed first and foremost. With the at-risk youth programs that I've managed, same thing there. I never asked a case manager or anybody to make a home visit where they felt unsafe. And it might not just be, you know, all the time. It could be just a certain instance that day. Like this just doesn't look right, whatever. We've had other policies in place where as soon as they got into the residence, they would call me and say where they are, how long they're going to be there, so everybody there sees that somebody else knows where they are. And then I've even accompanied case managers that, yeah, you know, it's the first time and I'm not really sure, so come with me, no problems. We can we have ways where we can make sure that you feel safe. Just wanted to make sure that's it. Okay.
And I will add that there was a brief conversation about starting home visits up when I was here, and we were going to do it because the MSS nurses have always done home visits. It's a new thing for them to be doing phone visits. And so the conversation was that you would do it in tandem with the nurse, not alone. So, and like, I have never felt unsafe. there have been times where we've been worried about, intimate partner violence or something like that. Or there have been times where, the mom wants a doula and the husband says no. And like I said, it's so important to have constant conversation with your team, because when these things come up, it's usually a conversation with your supervisor. And even as a precaution, where, husband, loving, great, supportive person, but doesn't want a doula. Even though, you don't think anything's going to happen, my supervisor has been like, okay, you're just not going to attend that birth because we never want to put you in a situation that is not safe or you're not wanted, kind of thing. So I've never felt unsafe in my position as the doula.
Great. I had a question, and then I should have wrote it down in the chat. So
Sorry,
I'm sure
Richard.
all right, Holly, what do you got?
I just thought of when you were talking, how many cases do you generally have at a time?
The goal is one birth a week. And depending on how quickly someone gets enrolled in MSS services, like you could be juggling a lot of patients at once. Or like sometimes, you get a patient, 4 weeks before they give birth, or I've been given a patient a week before they give birth. So I would say it kind of ebbs and flows. Like there's periods where I have a bunch of patients on my schedule way in advance, and like I'm constantly doing visits. And then there's other times where it really is just like one birth a week, or maybe one birth every other week. And but that is the general goal. But I'm sure, as you all know, you cannot schedule birth. So sometimes multiple births happen in a week, and sometimes you have a couple weeks apart.
Okay, thanks.
Emma?
Yeah, what do you put in your go bag? Like when you attend a delivery, what are must-haves for you?
There's a really great book that like you'll learn about in your best year training, written by Penny Simkin. It's like the doula manual. So I would carry that around with me whenever I go to the hospital, because like it has a lot of great tips in there. So I have that book. I have like any kind of sanitary or hygiene products I would need. So like I bring a toothbrush and toothpaste and all that stuff, because you never know how long you can be at the hospital for 3 days. What else do I bring? I usually have a snack and water, just because sometimes it can be hard to get those stuff. So always making sure that you're taking care of yourself, and then a cell phone and a charger and a spare charger, because so many people forget to bring a charger to the hospital. So it's like, it's a good item to have.
All right, Holly, you have a question.
Sorry, my hand didn't come off somehow.
Oh, okay. Let me see if I can lower that. There we go. Okay.
Thanks.
I have
Yep, absolutely.
2 other questions that are sort of broader. You mentioned personal growth that you didn't really anticipate. Can you talk a little bit more about what areas of personal growth that hit for you, if you're comfortable sharing?
Yeah. I would just, it's so hard to put into words, and I think Richard can probably relate to this too. I had never been a part of a birth, like a live birth before. And like you see videos of it, in your best year training, or, in health class in high school. I saw videos, but like nothing can really prepare you for seeing like a baby born. It's really just such like, I think for the like first 10 deliveries I did, I cried every time. It's such an emotional experience. And honestly, like even witnessing a birth changes you so much. It really just gives you a new perspective on like life and um children. So that was, I mean, just that experience alone really changed me. But also just you become such a close, like it's such a bond that you get with your patients. Like I share the building with my MSS building is also in the same building as dental. So I see my patients a lot, and just like, even if I did their birth in September and it's now June, like, they always greet me with a hug. Like, you just have such a special bond with these people. I mean, you learn so many intimate details of their life, and you're with them for so much time. And I think that's something that is hard to describe, what you gain from this experience, but you really do. You learn how, like, I've gained so much patience because you are going to be in experiences where, you have like a stressful doctor, a stressful nurse, like the partner's tired, but you have to learn how to be selfless and like put your own needs and thoughts and feelings aside and just like support another person, even if like you don't agree with the decisions they're making. Um, y- maybe this isn't very coherent, but like you just learn so many life lessons about, how to support a person, how to put someone else's needs first, how to make someone feel comfortable and confident, how to deal with very stressful situations, um, how to deal with complex medical and social needs. Like if you go into this position with an open mind and truly like an open heart, like you will take away so much. Like the patients are so special and wonderful, and if you treat them with the respect that they deserve, they will definitely be giving so much more back to you.
That's really beautiful. It's very, very cool to see you light up talking about that. That is really inspiring.
I've often said to Laura that I can tell she learned a lot within the job, but that it's been a very spiritual experience for her. And I
Yeah.
can see it in just the way she talks about it. Going back real quick to home visits, as working with at-risk youth, we were all mandated reporters. So I don't know if you know what that means, but that, yeah, if you see something, child abuse or neglect, you need to report it. In your role, are you a mandated reporter, and do you communicate that to your patients?
I'm almost positive. Yeah, but I'm trying to think.
That might be
Be,
something we need to clarify with Paula.
yeah, because there are things that come up, and it's like a conversation you have with the patients, where it's like, like if we go any further in this conversation, like the police have to get involved, and sometimes that's not always wanted.
And they know
So
when to stop too. They know what to say a lot of times and where that line is crossed, and they'll stop and not give you that information, but infer it a lot.
yeah, yeah, definitely something to clarify before starting, because I know people on my team are mandatory reporters. Um,
And
because
I bring it up because if home visits are going to occur more,
mhm,
there's more opportunity to see things or experience things that would require a CPS call.
yeah,
And I know for myself and any programs I've that's never a decision I've ever left to the person individually. I've always advised them to consult with their supervisor, whether it be me or somebody else, before making that call.
yeah.
All right, thanks. Any other questions?
Just one last one, which is, what advice do you have for somebody stepping into this role, especially somebody who like hasn't been a doula before, or done this sort of work?
Yeah. Definitely walk into it with an open mind. Really like take the time to listen and learn. Don't feel like you know everything or need to know everything. Like be very honest with yourself with what your limitations are and what you do and don't know, and like take the time to learn and listen. Lean on your coworkers, and just really try your best to make sure that um, you are giving the support and the attention to each patient and each thing that you're doing that it deserves, because um, everything's a learning experience.
Holly, you have a question?
Yes, and I may have missed this by chance before, because I had a little bit of difficulty getting into the meeting. But after this is over, is there a possibility, is this a permanent position that they have at CMAR that they might move you into once you're done with this? Or is this just a position purely through AmeriCorps?
You know, I don't know. Are there any CMAR? No doulas on staff, so it's just an AmeriCorps position.
I think it's generally pretty rare for there to be staff doulas, because I know Swedish technically has staff doulas, but I've heard through the grapevine that they're getting rid of that program.
Oh.
And I think Common Spirit all the way down in Tacoma is trying to do something similar that Swedish has, but it's a very unique program that of the AmeriCorps doula, because doulas are usually independent contractors. And so you'll learn about that in your best year training, because most doulas work for themselves. But yeah, in terms of Sweden or CMAR, sorry, it's purely an AmeriCorps position.
Okay, I assume
I know-
that, but I just wanted to make sure.
Thank you.
I
Emma?
know part of the reason that doesn't happen so much that you have staff doulas is just because the licensure or lack thereof is really complicated. I wrote my undergrad thesis on doulas and incorporating them in health systems. And so I know that's something that is often a legislative and policy hurdle, is like, how do you have folks who have this experience and do this important work in a system that really looks for credentials and licensure, and how to navigate that varies state by state, but then also system by system.
Yeah, there's no insurance reimbursement for doulas.
Wow.
So that's definitely and I think every state is like that. I know there's one state that technically has insurance reimbursement for doulas, but then there's actually no way to go about getting reimbursement. So I think that's why I say a lot of people who have a doula usually come from positions of privilege, because you have to be able to afford the out-of-pocket cost of a doula.
I think in Minnesota, they are requiring licensure now. I just read this because I was thinking about possibly moving to Minnesota recently, and they do it specifically for the insurance reasons. That's why they require the licensure. And I think DONA is who they do their licensing through.
Interesting.
Okay. Well, we're up on the hour here. I did have one last question if we're prepared to end this. If some of you still have further questions, we can definitely find a way to get your questions to Laura. But Laura, you described what is a very emotional experience for the mothers and obviously for yourself. For anybody who works with people, you can't help but take that home if you care at all about what you're doing and the people you're serving. So if you could speak a little bit to, because I'm a huge proponent of self-care, as we've talked about. So maybe talk a little bit about what your self-care thing and how important that was to maintain that self-care to keep you going through it. You know, that's a tough year. I know I couldn't have done it. So, so if you could talk a little bit about that.
Definitely. So I would say, as a general rule, in the beginning, because as Richard mentioned, there's a 1,700-hour requirement, but there's also a 1-year requirement for AmeriCorps. And so in the beginning, you can be stressed about oh, I should really, work as much as I can, about hitting my hours. I would say that's absolutely not a concern in this role. And to flex your time. So if you, even if the birth is super fast, it falls in the 9 to 5 time frame, it can be stressful and very emotional. And so if you need to take the next day off, send a text or email Richard and your supervisor and just be like, hey, this birth was yesterday. I'm gonna come in the afternoon, or I'm gonna take the day off. You know, it was a 24-hour birth kind of thing. Is like flex your time and take care of yourself, because you can't, like, you truly cannot take care of people if you are not taking care of yourself, you know? Or like if I knew an induction was going to happen at 10 p.m., like I would go into work late. You know, there's no reason why I should be working like from 8 a.m. to midnight kind of thing. So flexing your time and like find someone who you can debrief with. So that's why I really liked sending those epic messages like after birth, because stuff will happen. There's stressful situations, emotions are involved, and it might be different, but some of the hospitals didn't have interpreters. So I would have to not only be a doula, I would also be an interpreter. And in that, my words would get muddled in, you know? So like as an interpreter, you speak in the tense that is being spoken. So, you know, I'd say like, oh, we are going to do this kind of thing. So like the patients start to see you as like not their doula anymore, as their interpreter, and like the words being your own, whereas you're really voicing what other people are saying. So that can muddle the situation. And so it's really important to one, have debriefs with everyone on your team so that, you know, if something happens, you have someone you can talk to about it, even if you're just, you know, for lack of a better word, venting. But then I always have postpartum calls 5 weeks after birth to just talk to the patient, you know, like how did the birth go? Like, what were your feelings? How are you processing it? Because a lot of times no one ever actually, you know, asks someone to discuss their birthing experience. And through those conversations, like I've like had patients tell me, they're like, you know, like I never thought this would happen, or like I never thought I would be in this much pain, or you know, I didn't realize I felt so scared kind of thing. So have debriefs for yourself, take time for yourself, and then also like give that space to your patients too, because it'll help ease all feelings through the process. But yeah, also learning to just kind of dissociate, like, you know, like doula work is my work, but I absolutely have to leave that at home and like find an outlet where I can just be myself, because especially in the beginning, it's so easy to let like unfortunately, our patients are just like they have they carry so much is going on in their life, and it can be so hard to like see someone in that situation and then, you know, like go home and live your life. But it's really important to learn how to separate the two, because otherwise it'll just eat at you, and you'll feel burdened by their burdens, and you really have to take time and space to separate that, because otherwise it becomes so hard to keep going. Um, and it's unfortunate, but and the people in the MSS department, they've seen everything. So like if a patient's going through something and it's really hard for you to process, definitely speak up and say like, hey, you know, like it's not silly. Just be like, hey, I saw this and I don't know what to do. Like I feel so vulnerable, or I feel so uncomfortable, and they'll help you through it. But it's really important to do that, because you're going to be seeing it all year, and you can't try to bottle your emotions.
All right. Well, thank you very much, Laura, for giving him your time. And you didn't even drink one sip of water. That was really good for you to
I
be
had my
doing that much
coffee. I would
talking.
mute myself. Don't worry.
Oh, okay, okay. So thank you all. Thank you all for coming. I really appreciate it. If you have more questions, you all have my email. Please feel free to send me those questions. If I can't answer it, I'll find the person who can. Like I said, after Friday, Laura is no longer here, but her site supervisor, Paula, would be helpful and such. The selection process, this is not a hiring process, because you're not being hired. You'll be volunteers getting a living wage stipend. So I'll be having phone interviews with those who return the email that I sent to all of you. And then the next phase from that would be a virtual interview with the site supervisor. And then we'll make our selections after that. So does anybody have any questions regarding that?
Can I ask a quick question about the stipend situation?
The what?
The stipend, the money
Oh, yeah, yes.
situation? So the position is listed as a 25 a year position. That is a number that roughly includes the education award in addition to the stipend, correct?
No, the living wage stipend, a living allowance stipend is exactly that. It's the
Oh, okay. I
modest
didn't
amount of
realize
money
that.
we give you to somehow scrape out a living. Laura's great. Her cardboard box is one of the nicer cardboard boxes that she inhabits. She's decorated it very well, made great use of space there, and has like 100 top ramen recipes that you can use. But yeah, that's just the living wage. The education allowance, $6,850, I believe. That is in addition after everything's completed. So
That's phenomenal.
and then also training counts in those hours. And then Laura's also volunteered her time for a Christmas toy drive, a conference program that I was having, a trash pickup, neighborhood trash pickup, and a Latino health fair. So there's other opportunities to pick up hours if somebody falls behind or things like that. So all of those count. So, all right. Any other questions?
The 6,000 at the end,
Mhm.
that can go towards more training, I'm assuming. So like more classes at Bastyr, that type of thing. Because I know there are a couple
Yeah.
of classes that I was hoping to take there as well that I'm assuming aren't going to be part of the training.
Correct. And then there is money for additional trainings throughout the course of the year. And we're trying to get a focus also on trainings that provide certification. So then when you leave AmeriCorps, you have certification for different things. I think there's I want to say there's a community healthcare. Laura, you're shaking your head.
Yeah,
What-
I think everyone, like both the patient health navigators and the doulas, will do the community health worker training through
There we
King
go.
County, or
Right.
actually it's through the Washington State Department of Health, and you get a community health worker certification from
There you
that.
go. There you go. So thank you. All right. Okay. Any other questions? All right. Well,
Laura, congratulations on finishing the year.
Thank you. It's bittersweet.
yeah, we'll miss her terribly. So, all right. Well, thank you all. I will be in touch hopefully within next week, and I appreciate your attendance today. Thank you.
Thank you very much.
Thank you very much.
Good luck, everyone.
Thank you. Bye.
Bye, Richard. Thank you.
Yeah. Thank you.
Of course.